Thank you for joining. And today afternoon, we'll be presenting a story of probably a baby was turned an adolescent boy. And through this case, we just want to highlight that the case is probably just representing the tip of the iceberg of a load of cases that we're seeing such kind of cases. So the case will be presented by Aliza and will be discussed by Megha. Over to you, Aliza.
Good afternoon, everyone. So today we'll be discussing tale of a child with an autoinflammatory syndrome. This child is 11 years old boy who is symptomatic since day 8 of life, having multiple episodes of fever associated with multiple erythematous nodular lesions. For these symptoms, the child has visited outpatient and inpatient and has been treated symptomatically with antibiotics and NSAIDs, but there was no relief. The fever episodes used to occur every 2 to 3 months and would last for 3 to 4 days and would resolve on their own. The erythematous nodules were present on face, torso, hand, and feet. These were non-pruritic and non-tender. Between the episodes, the child was essentially normal. There was no history of oral ulcers, alopecia, redness of eyes, joint pain or swelling, any bleeding manifestation, or history suggestive of any particular focus for infection or loose stools or vomiting. Child was spontaneously conceived, had uneventful antenatal period, born with full-term normal vaginal delivery, cried immediately after birth, and had smooth perinatal transition. He is immunized till date as per national immunization schedule. There has been no history of any adverse reaction after immunization, and there is no obvious history suggestive of immunization acting as a trigger for these episodes. Currently, he studies in 7th standard and has average scholastic performance. This is the family history of the child. This is the index case. 11 years old child who had an elder sibling with similar complaints, onset in neonatal period, and suffered sudden unexplained death at 14 years of age. This child also has a paternal cousin who is currently 2.5 years of age and is having similar symptoms with onset since day 8 of life. This child also had an elder sibling with similar complaints who died of sudden unexplained death at 4 years of age. This is the child, younger cousin, who is having similar complaints. He has also visited multiple doctors and has been treated symptomatically. On examination, the vitals of the child were stable. He had pallor, but there was no icterus, cyanosis, clubbing, edema, or any significant lymphadenopathy. During the hospital admission, the child was found to have erythematous palpable nodule present on the nose, which was non-tender and non-pruritic. He also had elongated and bulbous fingers. This is the picture of the younger cousin who also had erythematous nodule present on the nose. In systemic examination, the child had, the liver was palpable 6 cm below right costal margin. Spleen was palpable 4 cm below left costal margin. Other systemic examination was normal. So from history and examination, we can see that the disease is of neonatal onset, having periodic fever with erythematous nodular lesions, bulbous fingers are there, pallor is present, hepatosplenomegaly, and there is significant family history of sibling and cousin with similar complaints and sudden unexplained death. So from this history and examination, we could not make a particular diagnosis, but we could reach that autoimmune category of the diseases could be one of the possibility in which monogenic lupus or sarcoidosis can present early in age. The other category of diseases that we are traditionally told to think of with the fever are infection. Considering the age of onset, we can think of any perinatally transmitted infection like congenital syphilis or cytomegalovirus. Malignancy can also be thought lower down as a lower down possibility with fever and hepatosplenomegaly. But we often forget about another set of disorders, which are autoinflammatory disorders, which also present with similar complaints and has onset in neonatal period. The group of disorders in which neonatal period of onset can be seen is familial cold autoinflammatory syndrome, neonatal onset multi-inflammatory disease, proteasome-associated autoinflammatory syndrome. So keeping these differentials in our mind, we went ahead with the investigations. We can see that the child was having persistent anemia with thrombocytosis and raised inflammatory markers, that is ESR and CRP. The child also had raised C3 and C4 levels and hypergamma-globulinemia. As there is history of sudden unexplained death with one sibling and a cousin, we went ahead to rule out sudden cardiac death as one of the possibilities, for which we did 12-lead ECG, which was normal. Further, 24-hour ECG, that is Holter, was done, which was also normal. 2D echo was also performed, which was not suggestive of any cardiomyopathy, vegetations, or coronary artery aneurysm. Special thanks to Dr. Saurabh, Dr. Lamak, and Dr. Shiva Prasad for helping us in this evaluation. As the child had an active lesion during the hospital stay, we went ahead with the skin biopsy. So the results for the skin biopsy will be explained by Dr. Surbi from Department of Pathology.
So we received skin biopsy from the erythematous lesion. The epidermis was essentially, they hadn't mentioned on the hand. Essentially, there was a focus of mild hypergranulosis. The upper dermis showed moderate inflammatory infiltrate composed of lymphocytes, histiocytes, and few neutrophils. The deep and the mid reticular dermis showed dense interstitial inflammation, which was similar in nature. However, in this part, the neutrophils were more. Neutrophilic debris was also seen, and one small vessel showed evidence of neutrophilic vasculitis. However, there was no RBC extravasation or fibrinoid necrosis. This is the CD68 immunohistochemistry, which is highlighting all the histiocytes.
So with the evaluation, we can add that raised inflammatory markers and inflammation in the skin as one of the pointers to our disease. So further, the autoinflammatory syndromes can be considered as the possibility with the history, examination, and the investigation that we have done. So we went ahead to do the whole exome sequencing for this scale. The whole exome sequencing, we can see that the child was having pathogenic variant or pathogenic autosomal recessive variant of PSMB8 gene, and the child was homozygous for the same, for which he was manifesting the symptoms of proteasome-associated autoinflammatory syndrome. As he also had one cousin who is having similar complaints, we also did whole exome sequencing for the cousin, and also the parents, the whole exome sequencing was also done. The whole exome sequencing of the parents shows that the parents were heterozygous for the similar mutation. As the proteasome-associated autoinflammatory syndrome is an interferonopathy, we went ahead to do interferon signaturing for the child. For this, I would like to invite Dr. Lata, scientist from our department, to explain.
Thank you, Dr. Aliza, for suggesting that this patient has the PSMB8 gene variation. So when there is a defect in the PSMB8 gene, so they trigger the more production of interferon, which induces the expression of interferon stimulated genes. So these genes have the 6 panel of ISGs, which are known as interferon signatures. So what we are interested in this case, that we again further investigate the RNA qRT-PCR, which is a quantitative real-time PCR. So we took the sample and performed the quantitative real-time PCR for 2 genes, which are IFI44L and IFI27, which are the major interferon stimulatory gene in these cases. So we found that the gene expression level of these 2 genes were elevated in both the patients, so which suggests that they have the sustained interferon activities in these patients. So these tests are very tedious, and they are having the optimization are very difficult because of the expression variability in the expression level of these genes. So we are in the process of establishing these genes as the interferon signatures.
So regarding the management aspect, after reviewing certain articles, we have started the child on JAK inhibitors, tofacitinib, and so also he was started on oral steroids with tapering over 6 weeks. He was reviewed at 3 weeks and he was found that there was no further episodes of fever or new skin lesions, and also the CRP became negative after 3 weeks of therapy. A further follow-up is required to monitor hemogram and inflammatory markers to see the evolution of symptoms and to evaluate for end organ damage. So to discuss further about this disease, I would like to call Dr. Megha from our department.
Thank you, Eliza. Good afternoon, everyone. So, after reaching the diagnosis of proteasome-associated autoinflammatory syndromes, we are going to discuss about these topics in further slides. People are oftenly confused about these two terms, autoimmunity and autoinflammation. Autoimmunity is adapted immune system driven. However, autoinflammation is innate immune system driven. In adaptive immune system, there is release of T cells, B cells, and production of autoantibodies that are responsible for pro-inflammatory cytokine release and further autoinflammation results from this. Whereas in case of innate immune system, there are macrophages, natural killer cells, dendritic cells, and neutrophils that when they bind to a specific antigen causes release of cytokines, but there is no autoantibodies involved in this process. Autoinflammatory syndromes, they are caused due to dysregulation of the innate immune system with a genetic background of monogenic, polygenic, and multifactorial in origin, characterized by recurring unprovoked episodes of inflammation. If this episodes of inflammation persists for a longer time, it can involve various multi-organs like GI symptoms, and the patients can have GI symptoms, involvement of amyloidosis, in the renal involvement with the arthritis, rashes, and many and others. So there are three broad classifications based upon the mechanism involved in the pathogenesis of this autoinflammatory syndrome. We have inflammatoropathies, type 1 interferonopathies, and NFKB, and aberrant TNF activity, which leads to various diseases here and with varying degree of clinical presentation involving fever, myalgia, myositis, rash, osteomyelitis. But here we are dealing with proteasome-associated autoinflammatory syndrome. So these are the main pathways that are involved. In interleukin 1b activation, there is interaction of NLRP3 gene with the caspases and formation of inflammasomes, which further leads to cytokine production. In NFKB activation, there is mutation in NOT2 gene and further activation of NFKB pathway, pro-inflammatory cytokines release. And further in interferonopathies, we have DNA signaling pathways that leads to interferon type 1 interferons. Here in our case, the disease is based upon the type interferonopathies release, and here is type 1 interferons that is involved in the pathogenesis of the disease. So, what is the proteasome structure and how it works? The proteasome, basically, it helps in the breakdown of the proteins and breakdown of the proteins that are detected as a disposal particle. When the proteasome acts on the protein, it degraded into various peptides. But this happens and this is the cycle that happens during the cell regulation, DNA repair defects, and regulation of the cell cycle. This proteasome structure is mainly consists of two subunits, that is 20S, which forms the core and it has the catalytic property, while two regulatory proteins they are attached at the bilateral end of the proteasome. When constitutive proteasome comes in contact with various cytokines, it produces inflammaproteasomes, which has three subunits, beta 1, beta 2, and beta 5, and this is responsible for the catalytic property. But in case of PRAS, there is mutation of PSMB5, PSMB8 gene, which results into inability of this B5 subunit to interact with the proteasome and which further inhibits the pathway of degradation of the proteins, and this misfolded or unfolded proteins that accumulate inside the cell and leads to further inflammation and cytokine release. With this disease, going up to the prevalence, less than 1 per 10 lakh population has been involved. The age of presentation can be starting from neonatal period to 14 years and many more. Diagnostic delay with a median of 5 years, and PRAS is a rare disease with approximately 100 cases reported worldwide, mostly in Caucasian males. And among this spectrum of all these 4 PRAS diseases, scandal found to be the most common in presentation. So the clinical presentation may vary from a mild to severe manifestations. It can involve fever. The child can have fever, hepatosplenomegaly with raised inflammatory markers. It can involve skin with nodular lesion, lipodystrophy. Can involve heart with cardiomyopathies, arrhythmias. Lung involvement can be seen in form of ILD, lung fibrosis. CNS involvement in form of basal ganglia, calcification, seizure. Hematological manifestation may have anemia, leukopenia, thrombocytosis, and rest musculoskeletal and other involvement can also be seen. These are the clinical presentation. Initially, the child may have rashes and bulbous fevers, but if the disease left undiagnosed or untreated, that can have severe presentation with significant joint deformities, lipodystrophies, and significant rashes, arthritis. So this is the spectrum of PRAS constituting 4 different kinds of syndromes. In our case, mostly the child having early age of onset with nodular lesions with anemia, mild leukocytosis, raised inflammatory markers, hepatosplenomegaly. The most possible diagnosis we can have is scandal, which is chronic atypical neutrophilic dermatosis with lipodystrophy and elevated temperature syndrome. So for this disease, we have various treatment modalities like corticosteroids, conventional DMARDs, JAK inhibitors, and later on for a severe disease, HSCT can play a role. Whereas the corticosteroids have some role, but not very good, because after stopping the drug, the child may have relapse. The treatment that we have is the JAK inhibitors. Mostly they works as when the interferons act as a ligand, they bind on the receptor, they causes activation of the JAK-STAT pathway, and further this leads to transcription of further interferons, and which is a vicious cycle that further lead to activation of JAK-STAT pathway and further interferons release. There are various case reports in which many of the drugs have been tried, like cyclosporin, azathioprine, IV, tocilizumab, and steroid, but none of them has shown significant improvement. But in cases where tofacitinib and these JAK inhibitors use tofacitinib very successfully, we have seen significant improvement. This is the case series of 18 patients who were treated with baricitinib, where for a mean duration of 3 years, it has been shown that the median daily symptom score decreased from 1.3 to 0.25, and in 14 patients receiving corticosteroids at the baseline, we were gradually able to taper off the drug of the steroids, and among 5 in 10 patients with candle achieved lasting clinical remission. So these are the clinical pictures showing clinical improvement after treating with a JAK inhibitor. Outcome, it has a significant morbidity when there is systemic involving cardiomyopathy, ILDs, lung fibrosis, and vasculopathy, with a high mortality rate if untreated, approximately up to 30%. So here a key message will be unexplained inflammation. We surely have to consider about autoinflammatory syndrome. Early diagnosis can prevent accompanying morbidity and mortality. JAK inhibitors may be a potential therapeutic option. Thank you.
Thank you so much, Aliza, Tanya, and others. So I think through this case, what we want to bring to the house is probably the traditional teaching whenever we're dealing with how many residents are there. For the residents in particular, the traditional teaching whenever evaluating a child with persistent and long-standing fever is to think about infections, autoimmune disorders, malignancy. But we want to challenge this traditional thinking, not challenge, to augment the traditional thinking with another group of disorders which is known as autoinflammatory disorders. And as has rightly been explained in this particular case, they can have a wide spectrum of clinical presentation, which can start from day one of life or day eight of life in this case. By that I mean they can present as early as neonatal period to as old as 14 years, 20 years, or they can reach undiagnosed to my colleagues in adult rheumatology or dermatology to very specialty. Another important parameter or point that I want to highlight here is the clinical manifestation would depend on the underlying genetic variant. For instance, these kids, two kids had just mild fever, erythematous nodular lesion, whereas there were other set of disorders which has a horrifying lipodystrophy, joint contractures, and as a persistent ongoing inflammation, they can also have end organ involvement. So by that I mean that they don't respect the boundaries of organ system and they can visit any of the specialty, including all of us who are sitting here. And for instance, they can present to pulmonologists with ILD, they can present, even a radiologist can look and miss out on, not miss out I would say, but I want to appeal them to trigger the sensitization that if they are seeing a basal ganglion calcification, which could be normal, but which may not be actually normal, the child or the patient may be having that. And then the third point, of course, is whenever we are dealing with a child with a persistent unexplained fever, we are not able to trigger or point out an infectious cause. Please stop giving tons of antibiotics like these kids have been receiving for so long, and for sure, not tuberculosis. So with this, before I take further questions, may I take a few comments from particularly maybe Dr. Narang from you. We have a sibling with two sudden death, and I'm thankful for your department for helping us out for evaluating these kids. So what are the possibilities? We were thinking that arrhythmia has been reported. Another possibility which was coming to my mind was probably this could be that coronary inflammation, which might lead to sudden unexplained death. Your thoughts on this?
But I'm concerned actually about two things. That the sudden death is the
Yeah.
family, so we have to be very careful.
Yeah.
And I was looking for whether in the genetic classes which we have done very well, like no sequencing, we found one gene also. But you should look for tendinopathy genes also. Because this family may have tendinopathy genes, which like Brugada, long routine, was not really, but these genes can be present and they can cause ignorance. In various slides of the presentation, you mentioned cardiomyopathy and arrhythmias repeatedly, and so therefore we need to look for that in detail in the genetic aspect. Secondly, even though they may not be having the phenotype, voltage is normal and the echo is normal, but two things are there. Voltage either it's a longer duration voltage also available, 7 days.
Okay.
Sometimes we are able to, I mean, we did not pick up on 24-hour voltage, but we do a 7-day voltage, we picked up. Secondly, the echo now is normal, but the patient as well as the other family member, it should be very regular echo checkup, maybe an annual it should be done. So that because finding it sometime later, hypertrophy or enlargement of part of the myocardium. And thirdly, of course, as probably inflammatory process related to more myocardium and myocarditis, we talked about that. So even though cardiomyopathy is not a true myocarditis is probably inflammatory syndrome, we also we have to look for that. And generally, I don't know, that could be done to find out which organs the inflammation is there and one can localize more accurately. That also can be done.
Okay, thank you. Comments from everybody is, I mean, the house is open for discussion. Yeah. Yeah. I don't have a real explanation. I was just wondering, but honestly speaking, I don't have a real explanation for that. Sir, your comments. Dermatology. because another thing is that these patients you might be seeing more than us, lots of skin rashes and febrile illness. Yeah. So I want a message from you so that we don't miss out on that.
Diagnosis to make, but people once get sensitized to it, and 5 years ago, we would think about it once in a long while. But now, it comes up as a differential diagnosis more often, and some very good documents. I think that the rest of the world is learning to recognize autoinflammatory.
Yeah. So yeah, I think the key is they can come to any specialty, including the surgeons who might be thinking that they may not come to you. Actually, they can come to you, and you should think when you should think. Probably when it's sterile peritonitis, recurrent sterile peritonitis. Please give rest to your knife. Think. Uh, okay, that's a very great question. No real answer. No, but it's very important because these are driven by the mutation, and probably the I think the answer probably is in inverted commas lifelong. And what we do for most of the chronic disorders is we will look at the aim is to taper the steroids as early as possible. That's number one. And if the disease is in remission for at least 2 to 3 years, traditionally we think of tapering or stopping. But in such conditions, I'm afraid that we'll be able to stop them or not. Maybe my comments from colleagues in adult rheumatology.
So I agree with sir in that respect that the first goal is to take it. From another perspective as well, if the gene is targetable, it's good. That will be definitely. Till that time, depending upon the underlying pathway, it's like if they are ill. So based on the internet pathway that we decide, and the definitive therapy would be metabolic strength.
Yeah, so it depends. So fortunately, the JAK inhibitors and tofacitinib is affordable, and I think 30 tablets would cost around 1,000 to 1,500. But that is a bit unfortunate also because of lack of regulations. They are often misused, like in any drug. That again is a challenge. And important to note that whenever we are giving JAK inhibitors, again these kids, particularly the adults, are at increased risk of thromboembolic episodes, and the risk is, I would say, not less if not more than in adults, in children as well.
What about this diagnosing?
Okay, so people have tried a mix of that. Nothing works really great. It actually depends on the clinical spectrum, which will depend on the mutation, the variant. Some kids may respond, but mostly would respond. The best data we could get is for JAK inhibitors, and the refractory cases or the cases with severe clinical manifestation, the answer is hematopoietic stem cell transplant. Maybe dermatology colleagues can give a light on the culture scene because probably or depth on.
Yeah, theoretically speaking, because this particular disease is infiltrate in the dermis and axon and colchicine are traditionally regarded as anti-inflammatory drugs. So one would consider trying them out. This particular disease is also characterized by an increased interferon gamma signal. And interferon gamma signals do that. So it has a very direct mechanistic basis of there is a very strong rationale to use JAK inhibitor, because it is targeting the main pathway that is contributing to it. But surely, I'm not sure if someone has really tried the broader non-immunosuppressive immunomodulators like colchicine and probably they could work.
But not with great effects.
Imagine colchicine to be the drug of choice.
Yeah.
But it is. So someone has to try it out and then see. But as far as theoretical knowledge goes, JAK inhibitors have a very specific direct. So it's an endocrinopathy, and JAK inhibitors would probably be the best drugs. This is that.
Yeah, do agree. maybe we can try in few cases. Any other comment or question before we close the case? Thank you so much.